along with the catheterization data, were the symptoms improved in the people in the treatment group with the white squares. Their number of hospitalizations and need for medication and treatments was half. And it was well established in this very carefully done study. As Dr. Ornish has always said, if you do a very carefully done, precise study, you don't necessarily need 1,000 people. You want to figure out if a parachute works jumping out of a plane, you need maybe one example of the control group. You're not going to do 1,000. So he had very precise measurements. No disrespect for people that do skydiving. You're not going to see me doing that with a parachute of any kind. All right, that was 1998. Then 12 years later, with a lot of persistent work, both the Ornish organization and the Pritikin organization finally convinced Medicare that they had enough data, because they went on and expanded the numbers. Ultimately, for the Ornish program, there were more than 3,000 patients described that had been treated. And in the Pritikin program, as you saw, there were similarly thousands of people. That Medicare said, we'll approve this special kind of cardiac training, cardiac rehabilitation, but only after certain situations, not for prevention. For people with chronic angina, for people with recent bypass, recent balloon or stents, recent heart attacks, recent valve surgery, we'll pay for it. So there's always been a program for many decades called cardiac rehabilitation. But now we had something called ICR, intensive cardiac rehabilitation. And it is now, help me out here, 13 years later, and there are a lot of these programs, but there's still a fraction of the number we need. Dr. Ornish's program has just gone on to become a virtual program. So you don't have to find a facility in your area that will supervise you on site. You can do it at home with live Zoom group meetings, fitness, cooking, meditation, and yoga. Exciting stuff. I'm sure if you go to ornish.com, you can learn more about that. You have to bring up the famous, the energetic, and the wonderful Dr. Caldwell Esselstyn at the Cleveland Clinic, a surgeon who transitioned in the 1980s to have a hunger to learn about and then stop heart disease using nutrition. He published real research at the Cleveland Clinic in medical journals, a strategy to arrest and reverse coronary artery disease, a 12-year longitudinal study of a single physician's practice. He's published updated research in as many as 198 patients that he has counseled, I think in about 2014. God bless, at age 89 plus, he's still lecturing with great energy and vigor. You'll find him on many up-to-date YouTubes and even some meetings still. What did he do? He created a diet. He excluded added oils, fish, fowl, meat, and dairy. And he created a plant-based, very low fat content diet. He did allow statin medication to be used if needed to control the cholesterol. And he encouraged exercise, but it wasn't a structured part of the program. Dr. Esselstyn is famous for his insistence that oil injures the endothelium, the inner lining of arteries. We're going to talk about that a little later on. Ask ourselves, is that still the modern science or not, without any disrespect? But he also published some of the most famous pictures in medical journals about heart disease reversal using heart catheterization, not the modern coronary CT angiogram. I can show you from my clinic examples of dramatic reversal using coronary CT angiogram now, but at the time you had to go inside the body and inject the dye. And on the left in 1996 and on the right in 1999, there is major improvement of a narrowed segment called the distal left anterior descending or left LAD artery associated with dramatic clinical improvement. So yes, heart disease is reversible with diet and lifestyle. I'm going to go off on a little tangent, which is a controversy that exists certainly on Twitter and to a small degree in the actual medical literature. but to a very small degree in the standard cardiology and academic world. That of all the diet aspects that might be related to heart disease and might be modified by diet to lower the risk of heart disease or reverse heart disease, saturated fat remains in the focus. In all worldwide guidelines from international organizations, for example, in America, the American Heart Association, it is to lower the saturated fat. That's different from the trans fat, which should be lowered too, but has largely been eliminated as a food additive. Is different than monounsaturated fats, different than polyunsaturated fats. Those are usually coming from nuts and seeds and various oils. You want to lower the saturated fat. Why? Because in the 1950s and 60s, a hypothesis was brought up that foods high in saturated fat, like marbled meats and cheeses and whole dairy and egg yolks, and I would add coconut oil and palm oil, raise blood cholesterol, serum cholesterol. Serum cholesterol, LDL-C, is circulating, and if there's injured endothelium lining of the arteries, it can be incorporated into the inner lining and start an inflammation and irritation and get a whole chain reaction that leads to plaque. And if that is ongoing over years and years, it'll be narrowing, and then you can have it rupture, and you can have a heart attack, or you can have a situation where you have to go to the emergency room, or you can have a situation where you have SCD, sudden cardiac death. So saturated fat is a risk factor, not the only risk factor. Some people eat diets high in saturated fat and don't drop dead rapidly. There's no doubt it's a risk factor. Some people smoke and don't get heart disease and cancer, but you wouldn't encourage it on a public health basis. Test, not guess. Know your arteries, please. And the reason we learned a lot about saturated fat was this gentleman, Dr. Ansel Keys. He had 2 PhDs, professor of epidemiology at University of Minnesota. He died in 2004 at age 100.5. His diet worked pretty well for his longevity. And he made this observation. If you notice the graph he's pointing to, it's an actual graph. That in the city of Minneapolis, there was an overall drop in disease rates, except for one disease called heart disease. And the heart disease rates were going up and up. And he did a study of executives in Minneapolis in the late 40s, one of the first done around the same time the Framingham study was just starting outside of Boston. And he got very interested in the role of diet when he talked to colleagues in Naples, Italy, who said they rarely ever see a heart attack. And he said, we have so many heart attacks in Minneapolis, it's a problem. And he went and visited Naples, and he learned about the Mediterranean diet, which was not yet known in the United States. And who's responsible for educating the United States about the Mediterranean diet? Dr. Ansel Keys. He wrote 3 books on the topic. I'll show you. And Dr. Keys got co-researchers in 7 countries and 16 communities to get different styles of diet. United States diets, Finnish diets, Yugoslavian diets, Japanese diets, Greek diets, Italy diets, Netherlands diets, very different fat contents. And they followed these people from 1958 to 1970. Was all men, about 12,000, observational, extremely detailed studies, all done before the internet, before there were laptops. Incredibly hard work on a small budget. And what stimulated Dr. Keys was this kind of observation. Not all fats were the same for the risk of coronary artery disease. If you look to your left, in Japan in the 1950s, when Dr. Keys visited there, certainly in the area of Okinawa, the overall percentage of calories from fat, that's the purple bar, was about 10%. That's low. That's why Okinawa is famous. And the number of coronary heart disease cases in 10,000 men was very low. That's why Okinawa was famous. But if you go over to the Mediterranean basin, and I guess Finland is not exactly a Mediterranean country, but you can see, compare Finland and Crete. Crete is very Mediterranean. The percentage of calories from fat were about 40% in both locations, Eastern Finland and the island of Crete. But the heart disease rates were more than 15 times different. There was the highest heart disease rate in the world in Eastern Finland, and exceptionally low, even lower than Japan. But they were having all that fat, Dr. Kahn, in Crete. But if you look below, it was not the milk, butter, and sausage of Eastern Finland, which was the source of a high saturated fat diet. In Crete, it was olive oil, and olive oil can be quite low in saturated fat, particularly extra virgin olive oil can be quite low. It's not zero, but it can be 10% or less in good quality extra virgin olive oil brands that are very high in polyphenols. Plus, it was all those wonderful fruits and vegetables, whole grains, and legumes that make up the Cretan diet, the Mediterranean diet. So not all fat was bad, Dr. Keyes showed. His 7-country study showed it was saturated fat in the diet. Those meats, those cheeses, those egg yolks, those pastries. Pastries were very dangerous, like croissants with all that butter and white flour. And the higher the percentage of calories and saturated fat in these locations, the higher was the heart attack and death rate. So Dr. Keyes wrote books about the wonderful Mediterranean diet. He wrote them with his wife, Margaret, and they became the mainstay. They were all enormous bestsellers starting in the 1960s and 70s, and that's why we know today about the Mediterranean diet. Thank you, Dr. Ansel Keyes. His Wikipedia used to be a very ugly negative bashing of Dr. Keyes by paleo and keto people. It still happens all the time on the internet. But I wrote a couple biographies of Dr. Keyes, and it swayed the pendulum. So now his Wikipedia is much more balanced. All right, let's jump into this topic in a little detail. We'll get you awake here for sure. Does olive oil harm arteries? Should I be going no oil, no oil, no oil? And you just have to understand that arteries are a complex structure. But the inner lining we often talk about is like a wallpaper, one cell thick called the endothelium. There's actually a mucousy coating on the endothelium called the glycocalyx, even more protective. So we have several mechanisms to prevent those plaques from getting under the endothelial cells and starting to become clinically relevant by maintaining a healthy glycocalyx, Glycocalyx, eating green seaweed and brown seaweed and something called fucodin, which is a supplement may help your glycocalyx, and keeping your endothelium healthy. So, smoking damages the endothelium, diabetes damages the endothelium, high blood pressure damages the endothelium. We have reason to believe that high saturated fat foods like coconut oil damage endothelium. But what about olive oil? All right. My hero, my friend, my colleague, my mentor. So there is a process to measure blood flow in the arm. And remember, an arm is not a heart, but an arm is available for research, and an arm has arteries, and the arteries have endothelial cells too. So it's a model to evaluate, does a intervention like a drug or a diet lead to more blood flow or less blood flow? Is the endothelium appearing to be happy or hurting from whatever the intervention is? So here's a study from 2007 where olive, soybean, and palm oil intake were given to healthy young subjects, 10 healthy young volunteers. They got potato soup, and then there was 2 ounces of the oil, the 3 different kinds of oils. It could be fresh oil, could be fried oil. Oh my God, what happens with fried oil? It must be totally distorted. Anything good about it? Anything good in olive oil is totally gone if you've got fried olive oil. They measured at 1 and 3 hours this flow, and in all meals, didn't matter what the oil was, the flow that was measured dropped by about 1/3. But they didn't do a control group. They could have done the potato soup without any oil. I would suggest you that there would have been a drop in flow-mediated dilatation, because every meal causes a transient drop in flow-mediated dilatation. I'll show you that in a minute. And salt causes a transient drop. There probably was a fair amount of salt in the potato soup. So you might say oil is harmful. I would say food is harmful, and salty food is harmful, and fried olive oil is harmful, no doubt about that. There is this event, just to know, called metabolic endotoxemia. I've given lectures for over an hour just on that topic. But if you look at the bottom left, in animals for sure, high fat feeding like coconut oil can cause some changes in the gut lining where you get more spaces between the gut cells. They're called enterocytes. They allow some products from the gut, bacteria and toxins, to enter the body that aren't really welcome in the body. This happens after every meal, but it can happen more or less. And those toxins can lead to inflammation and changes in metabolism, like high sensitivity C-reactive protein, an elevated blood sugar, an elevated hemoglobin A1C, other markers of inflammation like myeloperoxidase. This is an animal study. And looking at the release of these toxins from the gut into the blood after a variety of meals. Now, it is an animal study and was done for up to 5 hours. Not exactly a perfect example, but it's famous. I want you to see that if they gave these animals the blue column called saline, anything you do and put in the gut causes a little bit of release of toxins. It's the nature of feeding. It went up 5-fold. If you look at cod, fish, and vegetables, it wasn't much of a rise. Olive oil was a little bit more than cod, fish, and vegetable oil. But coconut oil was the winner of the award for the most irritating to the gut cells and the most releasing of endotoxins. When people say, well, coconut oil is a healthy choice, that I push back a little bit because coconut oil is 85% generally saturated fat, and that is higher than anything else on the planet I'm aware of, palm oil being right there with it. Let's talk about this study. Let's break this down. These are pictures from the Game Changers movie, if you remember. This is the famous Dr. Robert Vogel, M.D. study. That's Dr. Vogel in the check shirt. He was my mentor at the University of Michigan over 40 years ago, still a wonderful senior cardiologist for sure. And he published this study in 2000 that many people quote. Yes, the Mediterranean diet is good, and it's good on endothelial function, but are some parts of the Mediterranean diet better than others? Is it maybe the fruits and vegetables are good, and maybe that olive oil isn't good? So he did a study where he gave some healthy volunteers, and if you quickly look at the study, he did that flow-mediated dilatation evaluation on the arm, FMD, and you could conclude, if you quickly read the paper, that olive oil reduced the flow-mediated dilatation 31%. The other meals did not. Olive oil damages endothelium. No oil, no oil, no oil. But that's not the case if you actually read the paper. Number one, if you look at the heading of the paper, table 2, there only were 10 healthy subjects, and it only was a few hours of follow-up. This is not a real-life heart disease patient example, but take it for what it is. There's 2 segments here. It's called preprandial. What was the measurement before a meal? Postprandial. What was the measurement for a few hours after a meal? And there were actually 5 different meals. The only one anybody talks about is the first column. When you eat olive oil and bread, the measurements in these 10 volunteers, the flow-mediated dilatation went from 14 to 9.9. That's called FMD percent, down about 31%. Looks statistically significant. It looks like maybe a bad idea. Well, look what happens when you have canola oil in bread. The FMD drops, but not statistically significant. Does that mean that we should be using canola oil because it's okay for the endothelium? What about salmon and crackers? Same thing, dropped a little bit, not much. We don't encourage salmon in our diet, but this is science. What about olive oil, bread, and antioxidant vitamins? The flow-mediated dilatation did not drop like it did without the antioxidant vitamins. Maybe we can have olive oil for the gourmet nature of it and just take some antioxidants. And then I want you to look way to the right. The real deal is the way people eat in Italy. Olive oil, bread, salad, and vinegar. That's called a panzanella salad. What happened to the flow-mediated dilatation even though there was olive oil? It didn't statistically significantly drop. All the meals dropped. Every meal drops. When you eat, you create metabolic endotoxemia. and you get a very small, transient, innocent, unimportant release of toxins in the blood that affect your endothelium. So one option would be to stop eating everything. Not going to work very well. We got to judge. And I argue that if you eat like a Mediterranean and you look at this data, you would not be pounding the table, no oil, no oil. Your endothelium can tolerate a real meal. Again, the reason this happens with every meal. So this is a beautiful picture of a panzanella salad: bread, salad, tomatoes, vinegar, and olive oil. And it's delicious. And according to Dr. Vogel's study, it's relatively harmless on your endothelium. Now, I wouldn't put chicken on it. I wouldn't put salmon on it. I wouldn't put cheese on it. I think that's some artichoke heart in there, not cheese. I would not do that. But according to the data, it doesn't get 2 thumbs down in terms of endothelial function. What are the limitations of the Vogel study? Very small, 10 volunteers, 3 hours, not heart patients, no olive oil only group. Remember, it could have been the bread they were eating in the famous column 1. It was extra virgin olive oil, but we don't know what brand. And I'm telling you, there's a difference. There is something nowadays available called high polyphenol extra virgin olive oil. They did not use. That's probably the healthiest version. And finally, vegans weren't studied, and vegans have different microbiomes, and vegans tolerate certain dietary insults or options or choices different than omnivores. So we don't know for sure.